It really is a pleasure being with you all today. I will be speaking, as was noted, on aging, health, and human flourishing, an epidemiologist's perspective. And it will be an epidemiologist's perspective in two ways. First, I will be going through analyses from a number of large epidemiologic cohorts. But secondly, I do want to bring reflections with regard to epidemiologic methods into the discussion as well. So I'll make a few remarks on aging and the role of religion in the aging process. I want to spend some time talking about some of the methodologic challenges in this sort of work, and this will be coming up repeatedly, and I'll present towards the end some kind of puzzling results where I do think the epidemiologic methods perspective really does help. Much of my presentation will be going through some analyses from the nurses' health study data. This group was about age 62 at the beginning of follow-up, and then followed for another 16 years in the analyses that I will be presenting. So that will give some sense as to the role of religious community on depression, on longevity, on suicide. But then I do want to broaden the perspective and talk about other outcomes, about human flourishing more generally, and sort of an analytic approach, outcome-wide analyses that can help us understand the role of religious community in the aging process, not just on one or two outcomes, but on a whole set. And I will conclude then with some discussion of implications for public health and clinical practice. Most of the analyses, though not all, as I will come to, will be coming from the nurses' health study data and the health and retirement study data in the United States, funding from the John Templeton Foundation. So we might think that religion could help address some of the concerns of aging, questions of longevity, of mental health, of healthy aging, memory, mobility, functionality. And we might think so because of a number of potential mechanisms, maybe increased social support, maybe something more cognitive, beliefs, hope, systems of meaning and understanding, possibly healthy behaviors. And it's worthwhile investigating these explanations. But there are challenges in this work. As an example, and I think an important, informative, instructive one, numerous studies, hundreds of studies have shown that religious participation is associated with lower depression. In Harold Koenig's Handbook of Religion and Health, the second edition, reports that out of 272 cross-sectional studies published since 2000, 63% suggested a protective association, only 6% detrimental. Of 45 cohort studies since 2000, 47% had suggested a protective association, only 11% detrimental. So again, looks like evidence for association, but most of this is coming from cross-sectional studies. Over 85% are cross-sectional. And this is potentially problematic because there might be effects in the reverse direction. As an example of this, Masalko and colleagues showed using longitudinal data evidence for the effect in a reverse direction. They showed that among women, depression at age 18 predicted lower subsequent participation in religious service attendance, controlling for baseline attendance. So there's evidence for reverse causation, which effectively renders cross-sectional data here useless for these analyses in terms of assessing causality, because we might observe an association between religious service attendance and lower depression, not because there's a true effect, but because those who become depressed stop attending services, as well as withdraw from other forms of social participation. So to address these questions, we really do need to take study design seriously. Unfortunately, and I'll come back to this point, there have been a number of large longitudinal studies, well designed with control for baseline outcomes, suggesting an effect in the other direction. But the analyses of Masalko et al. Make clear that really cross-sectional data cannot be used for these purposes whenever we're worried about effects in both directions. And there may, in fact, be such effects. And that is important to know as well. And I'll come back to that point also. And so more generally, in terms of thinking about study design and sort of a hierarchy of different designs with regard to robustness, to confounding, and to reverse causation, I think it's important to consider the relative evidence of different designs. Recently published a short piece on this, JAMA Psychiatry, kind of walking through these. But really at the lowest level of the hierarchy is cross-sectional studies, and it's very difficult to discern anything about causation typically from them. There can be some exceptions, but very challenging. The next best would be a longitudinal or cohort study with control for a rich set of demographic, social, economic covariates at baseline. Better yet still, and really in my mind, this is the minimum bar for establishing some evidence, at least for causation, is a longitudinal cohort study which controls for baseline outcome as well as covariates, because that really begins to make a step forward to ruling out these questions of reverse causation. Better yet still, and for reasons I'll describe shortly, would be to control for prior exposure, prior levels of religious service attendance, so that one's effectively looking at changes in religious service attendance, say, or whatever other exposures one is examining. Better yet still is sort of looking at whole trajectories of exposures and outcomes over time, and I'll make a few remarks on this as well. And of course, the gold standard in terms of trying to establish causation is often considered a randomized trial, but this is typically not possible in study of many aspects, not all perhaps, but many aspects of religion and spirituality. And too many of the studies on religion and health, I think, have been cross-sectional. We need to move, in my view, at least to this third level of the hierarchy, longitudinal studies with control for baseline outcome. And the reason for that, again, is to try to rule out reverse causation. If we're looking at potential associations between religious service attendance, say, and our outcome, maybe depression, then if earlier levels of depression affect both attendance and final depression, we might observe an association between religious service attendance and lower depression, not because there's an effect, but because those who become depressed are less likely to attend services. And controlling for baseline depression helps rule out that explanation, and it is sufficient to do so unless it's the case that a whole trajectory of depression affects both current attendance and final depression. And if that's the case, then trying to control for prior levels of service attendance can help further rule out that explanation of reverse causation. Controlling for prior levels of service attendance or the other exposure under study can also be helpful because it can help rule out potential unmeasured confounding. And that's because an unmeasured confounder, say maybe aspects of personality, conscientiousness, or agreeableness, which are associated both with attendance and depression, if we control for prior levels of attendance, then that unmeasured confounder, those personality factors, would have to affect both current attendance and depression through pathways other than through past attendance. And so again, that sort of analytic approach can help further rule out residual confounding and reverse causation. Sort of better yet still is kind of using a whole trajectory of the exposure, religious service attendance over time, and the outcome, so that one can look at how changes in one precede and might potentially affect changes in the other. One potential approach for doing so is marginal structural models and inverse probability of treatment rating models developed by Jamie Robbins at Harvard a couple of decades ago, which have become increasingly popular in the epidemiologic literature. I think this initial paper is now cited over 4,000 times in the literature. And these models really do allow for feedback between exposure and the outcome, between attendance and depression. Control for confounding is done by weighting rather than by regression adjustment. For those who are familiar with propensity scores, it's sort of a longitudinal analog of propensity score analysis, where one has a propensity score for each time point. So I'm not going to bore you too much with all of the technical methodologic details, but I think these are powerful techniques that can be used to try to address some of these issues. I've written a brief tutorial on the use of these methods, specifically with regard to religion and health, in this 2016 paper here. And I'll be presenting some analyses from the nurses' health data using these methods, as well as more traditional methods as well. So the analyses I will be presenting in the next 15 minutes or so will all come from the Nurses Health Study 1. There are now 3 of these, but the Nurses Health Study 1 was the earliest, started in 1970, in the 1970s, but starting in 1992, and every 4 years thereafter, they began measuring religious service attendance as part of a social integration measure. So these analyses will essentially be looking at religious service attendance in 1996 as the primary exposure. The sample here was on average age 62, but these analyses will give us some insight into the role of religious community in shaping health and well-being and trying to prevent decline in aging. I'll begin with depression, but I'm also going to comment on all-cause mortality, on suicide, and on a measure of healthy aging as well. Analyses of depression used 49,000 nurses, mean age 58 in 1992, but at the time of our primary exposure, 1996, they were about age 62, and then followed for, depending on the analysis, 12 or 16 years thereafter. Depression in these analyses was self-reported as being physician-diagnosed clinical depression or antidepressant use in 1992, and that was examined every 4 years thereafter. Depressive symptoms measured with the CASD scale. And again, these analyses look at religious service attendance in 96, but control for a rich set of confounding factors, which I'll go through on the next slide, in 1992, along with baseline depression in 1992 and prior religious service attendance in 1992, using these marginal structural models to look at the effects of religious service attendance over time on depression. So these analyses that I'll be presenting, again, control in 1992 for baseline service attendance and baseline depression, the prior levels of outcome and exposure, along with age, race, ethnicity, geographic region, a number of socioeconomic status variables, a number of social variables as well, various health-related variables, family history, and health behaviors also. And so when we fit these marginal structural models, what we're looking at is actually the cumulative effects of religious service attendance in 1996 and in 2000 on depression outcomes in 2004, looking at both the binary outcome and also a continuous measure of depressive symptoms. If you look first at the analyses for the effect of religious service attendance in 2000 on depression, you'll see the odds ratios here for those attending more than once a week, of about a 29% reduction in the odds of depression, confidence interval 0.6 to 0.8. And you see a dose response as well. So the greater the attendance, the stronger the apparent effect of religious service attendance on depression 4 years later. And you observe this as well when looking at continuous depressive subsequent religious service attendance. And so fitting these marginal structural models once again, but reversing the exposure and the outcome, one finds that depression in 2000 is associated with about a 26% decrease in the odds of attending religious services regularly in 2004. So a fairly substantial effect in the other direction. Also here, there does seem to, in fact, be some evidence, at least, for a residual effect of a depression in 1996 on service attendance in 2004, independent of depression in 2000. The estimate's modest, sort of a roughly 10% reduction. The confidence interval does have some uncertainty here, but perhaps evidence that being depressed even 8 years earlier still has residual effects on community participation, on religious service attendance, independent of what happens to depression in the following 4 years. And again, these models, marginal structural models, allow for these sorts of insights. One, of course, might still be concerned about potential residual confounding. These analyses adjusted for a rich set of covariates, but not everything. We didn't have data, for example, on the big 5 personality factors. And there is evidence from prior studies that conscientiousness and agreeableness are associated with greater attendance and less depression. And so maybe these analyses are still confounded. It's a real possibility, of course, with any observational data. So what we also did is employed a sensitivity analysis technique to ask how strongly attendance and depression to explain these away. And we used a technique that introduced to the methodologic literature a few years ago called the E-value. The E-value is sort of the minimum strength association on a risk ratio scale that an unmeasured confounder would have to have with both the exposure and the outcome to completely explain away the effects. It's very easy to use. We have online E-value calculators and software packages and Stata and R, but you don't need to use the software. You can just kind of enter the estimates into the online E-value calculator to carry out these sorts of analyses. But when we applied this to the present analyses, one can make statements like, to explain away our estimate of the odds ratio being 0.71, and unmeasured confounders and personality factors would have to be associated with both increased attendance and with lower depression by risk ratios of 2.1-fold each. 2.1-fold greater likelihood of attendance, 2.1-fold lower likelihood of depression, above and beyond all the measured covariates to explain away these associations. Even to bring the upper limit of the confidence interval to 1 would require an unmeasured confounder associated with both increased attendance and lower depression by risk ratios of 1.7-fold each. So again, pretty, I think pretty strong evidence. One can't be certain with observational data, but pretty strong evidence that at least some of this association probably is causal. The existing associations that we have for, say, agreeableness or conscientiousness are much, much smaller, maybe of the order of magnitude of 1.2 or 1.3, not 1.7 or 2.1. So I think these sorts of e-value calculations can be helpful in evaluating the extent and strength of the evidence address these concerns potentially of unmeasured confounding. So again, more details in the paper here and the online calculator, but this technique has become quite popular in the 3.5 years since it was published. I think it's been cited 1,200 times already because it's easy, very easy to use, implement, and describe in a paper. So I've been trying to encourage these sorts of analyses, both in the religion and health literature, but more generally, I think it's important to take issues of confounding seriously. So I mean, these analyses really just confirm, I think, what was something that was already fairly well established in the literature. I think the number of rigorous studies on religion and depression were already, I think, pretty good by the time of our analyses. In my view, it's one of the most strongly established outcomes, along with all-cause mortality. But did so with kind of better study design, repeated measures on both attendance and depression, a larger study, about 50,000 women, and methods to address feedback. Incidentally, since the publication of this, there has been a meta-analysis of restricted to longitudinal studies controlling for baseline outcome, baseline depression, suggesting fairly similar effects. I think this is really an important meta-analyses. There have been hundreds of systematic reviews and meta-analyses in the religion and health literature, but most of them group cross-sectional studies in. This one restricted to longitudinal analyses with control for baseline outcome. And the only other outcome that I'm aware of for which this has been done is all-cause mortality. So I think this was an important step forward. One has to be a little bit careful in the interpretation of the results of this paper, because they report results in terms of correlations, which make them look much more modest. If you convert them to odds ratios, you actually get estimates very similar to what we've reported here. But I do think that paper was an important step forward. But again, I do think the effects in both directions are, are likewise important. I think the effect in the reverse direction is important for religious communities as well, that those who become depressed may stop attending services, potentially exacerbating depression yet further. And so I think this work is in the reverse direction. It's likewise important for religious communities to be aware of, to offer support before those who become depressed withdraw from religious communities and other forms of community life. And again, I think methods that allow for feedback, allow for these sorts of insights. So much more briefly, I'll make some remarks on similar analyses with all-cause mortality and with suicide. So similar data, looking at religious service attendance in 1996 through follow-up through 2012 for all-cause mortality, controlling for that same set of confounders, along with baseline attendance in 1992 and baseline health in 1992. We use both Cox proportional hazards models here, and also these marginal structural models likewise use sensitivity analysis as well. And once again, with the primary analysis, the Cox proportional hazards model in this case, one observes a dose response function here where those attending more than once a week, about hazard ratio of 0.63, essentially 33% lower mortality risk, about 26% for those attending weekly. And once again, if one goes through these e-value calculations, you can conclude that for an unmeasured confounder to explain away these associations, it would have to be associated with both reduced mortality and increased attendance by risk ratios of 2.3-fold each. To explain away the upper limit of the confidence interval of 0.71, we need an unmeasured confounder associated with both increased attendance and lowered mortality by 2.16. So again, I think fairly strong evidence that at least some of, maybe not all, but some of this association is causal. Likewise carried out similar analyses with suicide as the outcome. Many religious traditions have teachings prohibiting suicide. I think this outcome's also of interest because it corresponds to one of the earliest religion and health studies that in Durkheim's suggested that suicide rates were lower in Catholic regions than in Protestant regions, attributing this to greater social integration and control amongst Catholics. Durkheim's analyses, however, were using ecologic data, group average data, which in some sense is even weaker than cross-sectional. So I will be returning to Durkheim's hypotheses with individual level data, but first wanted to just go through the primary main analyses with suicide as the outcome using a proportional hazards model. Again, essentially identical analysis to what we did with all-cause mortality, looking at service attendance in '96 on the risk of suicide amongst these nurses, essentially during their 60s and 70s, roughly until age 80. Controlling for the same set of covariates. Things are a little bit more challenging here because the outcome's relatively rare. I mean, in some sense, thankfully, there were only amongst this cohort, I think this analysis involved 90,000 nurses. Over the 16 years of follow-up, there were thankfully only 36 completed suicides. But from a statistical perspective, of course, that makes it more difficult to model. So in addition to our Cox proportional hazards models, we used an approach designed to deal with rare events, exact logistic regression, but one can control then for fewer covariates. So the exact logistic regression analyses employed only depression and social support, which we thought might be the two most important confounders. But the estimates from these two approaches were very similar, pretty dramatic reductions in suicide hazard ratio or odds ratio of 0.16, 0.17, so a five-fold, six-fold reduction, 85% reduction in suicide risk for those attending once a week or more. And if one applies these e-value calculations to these results, you end up with that to explain away that hazard ratio, one would need an unmeasured confounder associated with a 12-fold increase in the likelihood of attendance and a 12-fold decrease in the likelihood of suicide to explain away these effects. Weaker confounding could not do so. Even to explain away the upper limit of the confidence interval, 0.46, would require unmeasured confounder associated with increased attendance and decreased suicide by risk ratios of 3.7 each. And so big effects, I think, similar to those that have been reported elsewhere in the literature. And in one, I think, well-designed case control study at the time we published this, there was only, to my knowledge, one other longitudinal study looking at completed suicide, many on suicide ideation, suicide attempts, but only one other longitudinal study on completed suicide. But unfortunately, they were not able to control for baseline depression. But I think evidence has accumulated since. There have been a number of subsequent studies, a longitudinal controlling for baseline depression, say. And so I think the evidence here is now fairly good for an effect on suicide as well. We looked also at Catholic Protestant differences, and we had done so for depression and mortality, really found no difference there. Suicide was one of the few outcomes where we did find some difference. So when we looked at the association with religious service attendance stratified by Protestant versus Catholic affiliation, we found evidence for a protective effect for both Protestants and Catholics. Those attending more than once a week who were Protestants has a ratio of 0.334. So 66% reduction, 2/3 reduction, pretty substantial. But for Catholics, it was really a hazard ratio of 0.05, fairly wide confidence interval here, but a 20-fold reduction. So protective for both, but look larger for Catholics, large measure of multiplicative interaction p-value of 0.05, so kind of borderline. We can't be certain, but certainly the magnitude of the difference does seem substantial. So the kind of confirmation of Durkheim's hypotheses, but with individual level data. Interestingly, though, the differences only emerge with attendance. For those who are not attending, Protestant versus Catholic affiliation makes no difference. Effectively, it has a ratio of 0.97. So it sort of only those attending where we find an effect. And I think this is likewise consistent with Durkheim's proposed mechanisms of social integration and social control. Unless you're actually integrated part of this community, there is not much effect. Okay, so I've looked here at depression, important outcomes, depression, all-cause mortality, suicide, but of course, the literature on this is vast for other outcomes as well. And I think we now have evidence from rigorous longitudinal studies controlling for baseline outcome for effects of religious service attendance on the following outcomes. Not all of these are for aging populations. I will give that caveat, but in general, more widely in the literature, evidence for an effect on all-cause mortality, life satisfaction, meaning and purpose, less substance abuse, less crime, better social support, better marital stability, greater generosity, volunteering, civic engagement, pro-social behavior. So I think the role of religious community in shaping health and well-being generally, but also in the context of aging really is profound. And so I have increasingly come to the view that we should start looking at the role of not just religious service attendance, but effectively all of our exposures of interest on not just single outcomes, but a whole set of outcomes to try to more fully assess flourishing and well-being and the role that our exposures might play. And one can try to begin to do so, and this now corresponds to our more recent analyses using outcome-wide studies. I don't have time here to go through all the details of the implementation of these. I wrote a short description of how one might do this in 2017 in Epidemiology, and have a rather lengthy paper kind of laying out the methodology for these studies. But the basic idea is you kind of fix the exposure at a given point in time. In the nurses' health study, that might have been 1996, and then you follow not just one outcome, but a whole host, maybe 20, 30, 40 outcomes, controlling for prior confounders and baseline exposure and all the prior outcomes as well. But by doing so, by standardizing these analyses, it allows you to gain evidence for numerous outcomes kind of within a single cohort in a single paper. So we've now published 3 such papers on religion and health. We've employed this technique with other exposures as well. But we've published 3 outcome-wide association papers, one looking at religious upbringing in 2018, one looking at a representative sample in Poland and religious service attendance there on various health and well-being outcomes in 2019. And then one actually looking at 3 different cohorts in 2020, just published a few months ago in the International Journal of Epidemiology, their December issue, looking at young adults in one cohort, those in midlife in another, and a group that's aging, and from the health and retirement study. And so I'll be presenting analyses from this health and retirement study, one of the 3 cohorts in this 2020 paper. And so this was using data on religious service attendance, essentially in 2010, controlling for confounders and baseline outcomes and baseline attendance in 2006, and following outcomes through 2014. We looked at a host of outcomes, brief overview of the results, as we do find the evidence for an effect on all-cause mortality, hazard ratio here of 0.72. Not much on the incidence of disease, really very little evidence. Not all that much with health behaviors, with the exception of cigarette smoking. This is US data. I'm not sure it would play out the same way in Europe, but a 33% reduction in cigarette smoking. And then pretty substantial evidence for effects on various psychological outcomes, lower depressive symptoms, maybe some evidence for less hopelessness, less loneliness, greater positive affect, greater life satisfaction, greater social integration of non-religious forms, and greater purpose in life. But it gives a sense overall as to the entirety of the evidence across different outcomes. I think importantly, it also allows one to publish null results because they're incorporated into the same paper where you might be publishing positive results as well. So often null results are very difficult to publish in the peer-reviewed literature, but this outcome-wide approach allows you to see where there doesn't seem to be much of an effect, say with hypertension or diabetes or being overweight, for example. So we're now trying to implement these outcome-wide approaches in our religion and health work. I do want to present one final set of analyses where we did, on the face of it, and relevant to these questions of aging, seemingly find nothing, but where and it was surprising, but I think there are insights from epidemiologic methods which suggest why this might be so. And so we were looking in this work at different aspects of social integration, including religious service attendance, on healthy aging, using that nurses' health study data, so very similar design as to before, looking at service attendance in '96, following up through 2012 with regard to are these women aging healthy, where that was defined as being still alive and by 2012 still having no history of major chronic diseases, no self-reported no impairment in memory, and no impairments in physical function, no self-reported mental health issues as well. And when we did this, we found essentially no association with religious service attendance. Odds ratio here, 0.99. So almost exactly 1, really nothing. And so we were a bit surprised given sort of prior other evidence from religious studies. And as we looked into this more, we thought this might well be due to a certain form of selection bias, survival bias, essentially. Showed in earlier analyses that religious service attendance was associated with considerably greater longevity. And what that means is that the service attendance, that participation in religious community, might well keep alive those who are in fact unhealthy, those who, if they did not have that community support, might well have passed away. And so by essentially keeping those who are unhealthy, those who are struggling with real health issues, with memory impairment, with physical function loss, by keeping them alive, by providing hope, by providing a community that supports them, it looks as though there's no effect on healthy aging. Interestingly, in this paper, we also started moving the outcome measurement earlier and earlier. And as we did so, the effects became larger and larger. Just moving it 4 years earlier to 2008, one observes an association between religious service attendance and healthy aging. Odds ratio here, 1.48. So once again, I think that lens of epidemiologic methods is in fact important in thinking about these issues. I want to conclude my presentation in the next 10 minutes or so, 5-10 minutes, with some reflections on the implications of this work as I see it, concerning research designs and concerning understanding population health and concerning clinical practice. I've commented on this already, but I do think the potential for effects in the reverse direction means we need to take study design seriously. And I do think too many of our studies in religion and health are published with cross-sectional data that can sometimes be useful for novel inquiries, longitudinal analyses with control for baseline outcome. And certain parts of the literature, let's say on religious service attendance or religion, spirituality, and life satisfaction, the vast majority, over 99%, are cross-sectional. And so sometimes our evidence is coming from very few studies. That's not the case with mortality. It's not the case with depression any longer, but with many other outcomes, it is. And so I think we need to move towards longitudinal studies, and I think our meta-analyses need to move in this direction as well. Restriction to longitudinal studies with control for baseline outcome if we really want to establish strong evidence for effects. I think this also has important public health implications as well. We often think about public health impact of an exposure as a function of two things. First, the prevalence of the exposure, how common it is, and second, the size of its effects. Something that is common and has large effects on the outcomes that we care about will shape population health. I think religious participation is common. Worldwide, 84% of the world's population report religious affiliation. This, of course, is declining in the West, has been in Europe for some time, is now over the last decade or so much more dramatically in the United States than was previously the case. But just a few years ago, at least in the United States, 89% believed in God, 78% considered religion a very important or fairly important part of life, 79% continued to drop to about 30% over the last 5 years, even pre-pandemic. But still relatively common, declining in the West, probably increasing worldwide, globally, but still relatively common. And as we've seen, strong effects on the outcomes, the health and well-being outcomes we care about. It should be considered an important social determinant of health. I think it should be included in public health curricula as something that shapes population health. And I think neglecting doing so blinds us to the forces that are shaping health. As one example, here in the United States, the Center for Disease Control has expressed concern repeatedly over increasing suicide rates here. At this point in time where this paper was published, they had expressed concern about a rise from 10.5 per 100,000 per year in 1999 to 13 per 100,000 per year in 2014. During those same years, the United States Gallup poll reported a decline in weekly service attendance from 43% to 36%. And if one were to take the estimate from our study and extrapolate it to the US population, which is a jump, it is a leap, it is an extrapolation, but if one were to do so, it would suggest that about 40% of that increase in suicide rates was due to declining attendance. Again, if we don't talk about religion and spirituality in the context of health, we'll be blind to the forces that are shaping population health. Perhaps more controversially, does this have any role in clinical practice? As someone is aging, should a clinician speak to patient about these matters? And this, of course, has been an issue of some heated debate in the literature. I think one of the papers which still exerts considerable influence in the field is that by Richard Sloan and colleagues in 2000 in the New England Journal of Medicine, titled somewhat sarcastically, "Should the physicians prescribe religious activities?" Arguing at this time that endorsement of attendance is unethical, mature religion can cause tensions and antagonism, difficult for physicians to address these matters, religious views differ, people aren't trained to do so, should not be part of these conversations. Harold Koenig, I think in a very thoughtful letter, responded that really Sloan and colleagues were setting up a straw man and extreme position and attacking it. No one's arguing that physicians prescribe religious activities, but that's very different from recognition that these activities might be important in a person's life and their understanding of health, illness, and really clinicians could just take a brief spiritual history, and for those who are not religious or spiritual, discussion can quickly move on. I think another very thoughtful response to this came in a letter by David Nicklin, who wrote, "Practice, my experience could hardly be more in conflict with the conclusions of Sloan et al. Although I do not routinely inquire about patients' religious and spiritual lives, it is not unusual for me to do so. Most frequently, I ask such a question when patients are suffering from progressive, incurable, or fatal illness. It also seems relevant to inquire when patients are struggling with mental anguish or addiction. It is my practice to ask patients whether spirituality or religion is important in their lives. I then listen respectfully to their experience. Some patients report little engagement with these matters, and we go on to other subjects. Many patients talk of the central part God plays in their lives and in their experience of illness. Some describe the comfort and support they obtain from religious or spiritual sources, and I validate this response and encourage them. Some say they have lost touch with religion and spirituality and wish to reconnect with them, and we discuss that. We then go on to issues of diagnosis and treatment. I have had many hundreds of such conversations, and not a single patient has responded negatively. Their information informs my approach to patients in discussing their illness and their medical choices, sometimes in important ways. I come to know my patients in a deeper way, and they feel seen and heard in ways that matter to them. This approach helps me treat them and heal them, particularly when facing incurable illness or death. So I strongly believe that discussions of religion and spirituality have a role in clinical care as well. Many patients find it very helpful, and it's important to them in thinking about their lives and thinking about health or illness. But I do want to also come back to that more controversial question. Is it ever appropriate, ever ethical to encourage religious service attendance? And I think it's a complicated question. People don't make decisions about the religious commitments typically based on health. These things are shaped by experiences, upbringing, values, truth claims, evidence, relationships, and so on and so forth. But I do think that for those who already positively self-identify with a religious tradition, it would not be unethical to encourage attendance as a form of meaningful social participation. If people already say they believe these things, then I think encouraging participation in a community that holds similar beliefs is reasonable. I do think context is important. Important to try to be sensitive to potential past experiences of abuse in religious contexts. And I think uncovering that possibility might be facilitated once again by a spiritual history. And there have been various proposals for kind of 4-question spiritual histories. I tend to think in practice it's going to be difficult to accomplish this, at least in the United States. The time constraints of these clinical visits have become increasingly difficult. But I think they could perhaps be reduced to maybe even 2 questions, like, are religion and spirituality important to you, and thinking about health and illness or at other times? And do you have, or would you like to have, someone to talk to about spiritual matters? And I think if we did this, then a sensible, ethical, and sensitive approach could proceed as follows. After taking a brief, even 2-question spiritual history, religious service attendance could be encouraged for those who do already positively self-identify with a particular religious tradition. Other forms of community involvement could be encouraged for those who don't identify with a religious tradition. There are effects of other forms of community participation. Effect sizes might not be as strong, but they are still meaningful. And then for those who have had negative experiences or abuse, there could be referral to chaplains or counselors to try to work through these issues. I think an approach like this is sensitive both to those with religious commitments and to those without, to those who have had past abuse and to those who have not. And I do think an approach like this could potentially be implemented in practice. I think bringing these issues up is especially important in aging, in approaching the end of life, where guidelines are to inquire about religion and spirituality. Spirituality and religious community can also be a source of tensions or mental health struggles. And I think it's important to inquire also to uncover that possibility. And then patients often think these issues are important in their own medical decision-making. One study of cancer patients suggested it was of the 7 different factors, it was the second most important, religion and spirituality, second most important in their decision-making, ranked 7th out of 7 by clinicians. But for patients, it really is important. It should be incorporated. I think we can also turn the question around and ask, given that the effects of attendance, of religious community are so strong across so many outcomes, are we doing harm by withholding this information? That concludes my presentation. Thank you all for listening. Happy to take comments, questions for discussion. Thank you all again.
Thank you very much, Tyler. Excellent presentation in which you have presented both the data, the methodological challenges, and the implications. Very nice and very good for the whole conference here. So I think there are quite a number of questions. I've seen some things going on already in the chat. I would encourage those of you who already wrote a bit in the chat, if you could just perhaps speak out the questions you had there. Is that okay? I don't quite know who it was, but I saw some things going on. think it was Challing and Tobias. Maybe one of you could sum up.
Yes, I can do that briefly. I think the question was actually almost the same. So thank you for the very interesting presentation, Tyler. But so we were wondering, just as religious service attendance is such an important explanatory variable, if there was any evidence of which important dimension this variable composes of. So what kind of practices or what kind of community is it that is so protective? If you could comment on that.
Exactly, that was the same. I was very interested in what is the active ingredient of the religious service, which gives the protective effect on in preventing depression or suicide or excess mortality.
Yeah, no, I think it's a good question. I think more research on the topic is needed. I can offer my own reflections with regard to what I've seen and trying to, I guess, piece together the existing evidence. So I mean, I do think something about the communal life is really important, and if you look at analyses that look at private religion and spirituality and private practices, then the longitudinal analyses at least suggest very little association with health and well-being outcomes. It always seems dominated by religious service attendance. We perhaps don't yet have adequate evidence with regard to beliefs from large longitudinal studies, but private practices or self-assessed spirituality don't seem to have much association. So I think there is something critical about the community life. When we look at social support itself as a potential mediator, it does seem to explain some of the effects, but not all, maybe only a quarter of that on all-cause mortality, maybe half with life satisfaction. So it's something beyond just the social support there. So I think the community, the social support is important, but it's not the whole story. Likewise, when you look at other forms of community participation, I think you do find effects on health and well-being outcomes, but they're smaller in magnitude. So my speculation is that the community piece is central, but it's not just a community. It's not just any community. It's a community with a shared set of values, of beliefs, of purpose, of having a history that extends beyond the life of the individual. And so I think it's that community life supported by that common mission, that common understanding. And so my speculation would be other forms of community that resemble that, that kind of have a history, a lifetime, have a shared set of values and understanding and mission are going to exert stronger effects on health and well-being than those that don't. So that participating in maybe a volunteering organization or a political group would potentially have stronger effects on health and well-being than just showing up every week for a card game. I think even that will have some beneficial effect, but again, it might, I think, smaller than these much richer communities with a shared understanding, purpose, and history. So, from what I've seen, that would be my speculation.
Thank you.
Thanks a lot. So, Alistair, you had a question. Great work. I wonder if this is the time to move to complexity theory informed ideas of causality.
Yeah, I mean, so there's a lot of theoretical work on complexity theory and causality, and I think some of those can help uncover the limitations of the much cruder analyses. It's only one approach to try to supplement these empirical analyses. I mean, I do think qualitative data and analyses are likewise important, and trying to understand what really is going on to address that first question that was posed. What is it about these communities that really is contributing to the lives of these people? I mean, in terms of empirical analyses, there's, until recently, there's not been much to my mind, at least within the epidemiologic literature, of high quality, but that's beginning to change in the last few years. Some of the agent-based modeling approaches, I think, have been quite interesting and have begun to make real contributions rather than just constituting kind of more theoretical speculation. I haven't seen anyone carry that out with religious community, but it could be interesting. One of the concerns that sometimes raised when I present this sort of work is, well, participation in religious community might be good for the individual, but what does it do to the rest of society? Is it harmful to society? And is it increasing discrimination? I think more analyses on spillover effects, potentially using these agent-based models, could help shed light on it. I'm not sure it would play out in the ways people necessarily anticipate, because I think while these religious communities certainly are responsible for some harms, the sexual abuse scandals, for example, I think they're also responsible for a great deal of societal good, not just for the individuals, but often offering in many countries extensive medical care, food, in the United States, extensive food pantries, support for addiction for those who are outside of the community as well. So I'm not sure exactly how those analyses would play out, but I do think maybe these agent-based models drawing on complexity theory could provide some greater insight into sort of the spillover effects of religious communities on others as well.
I think there is a big project in the UK just initiated trying to measure the financial impact of different church and religious communities on service for the poor, etc., etc. That's coming up. There are 2 questions at least. Let me just see who was there first. Well, Arjan has a view on, in some overviews, the results of associations between religious attendance in Europe show less strength as those in the US, for instance, those by King. What are your thoughts about that? In our review on prospective studies on religion and depression, Harold Koenig and I did find this difference to a certain extent as well.
Yeah, I mean, I do think context matters. Again, my read assessment of the literature, it's not a formal analysis, is that the effects probably are stronger where religious participation is more common. I think there's evidence that in the vast, maybe not all, but in the vast majority of contexts, religious service attendance is beneficial for health and well-being. But I think the magnitude of those effects does depend on the context as well. I mean, as a sort of as an extreme example, I don't think there would have been much benefit to longevity attending services or identifying as Christian in first century Rome. The context is relevant, and so I do think it is the case when one feels one's not only participating in this community which holds these values and beliefs and understanding, but that is in fact also shared by the broader society. I think it just amplifies the effects more. So again, I mean, there are plausible mechanisms for the role of religious service attendance, with regard to social support, with regard to beliefs and hope, protecting against depression and suicide, say, and I think those are going to be fairly universal. But I do think the extent to which those mechanisms are in play really depends not just on the community, but on the broader context as well. So that would be my understanding of those results.
I think we'll take the last question. It was a bit returning to the implications. It's by Milutin Pankraj. I think it would be hard to suggest people to understand the connection between spirituality and health because they can think it is an attack on their decision and privacy. This result should be taught from early school age. Did I bring it forth correctly, Milutin?
Yes, that's correct. Thank you.
Yeah, I mean, once again, I think context probably does matter again, and maybe the the recommendations or what would be a sensible approach in the United States would be different from Europe, or maybe it would differ across various countries within Europe as well. Certainly some people do feel religion and spirituality are more private matters and don't want to discuss this in a clinical context or potentially in other social contexts as well. And that can then be respected. I think I would never advocate pushing this in a clinical context, only raising it as something that a patient might want to discuss. I think because it is very personal, it can feel uncomfortable for a patient to raise it, and simply asking the question gives them permission to discuss it if they want. If they don't, again, conversation can quickly move on. I think, and again, I don't have as strong a read as to what's taking place in Europe or different parts of Europe, but in the United States, I think the discrepancy between physicians in particular, it's somewhat less of an issue with nurses, but physicians in particular and patients is really remarkable with regard to how important patients versus physicians consider this, and with regard to wanting to talk about it. And I think for good clinical care, it is something that needs to be addressed. I don't think much is needed, but I think a single lecture module in the required curriculum would go a long way. Something like 90% of medical schools in the United States now offer elective courses on religion, spirituality, and health, but no one takes them. So no one has training. I mean, in our studies on end-of-life care, it's still like 90% of clinicians say they've had no training in this, despite it being part of palliative care guidelines. So there's real problem with the discrepancy between patients and physicians and lack of training. But I think a single hour and a half kind of reviewing the epidemiologic evidence, giving the two questions, which can be asked even if the physician and patient don't share religious beliefs, and saying, look, if you don't feel comfortable, just refer the patient to a chaplain, but simply raising it's really valuable. I think would go a long way. So that's what I would like to see happen here, at least. But again, I do think context is relevant, and sort of each country or region needs to reflect on these matters based on.
I think some of these suggestions would be even more relevant for a country like my own of Denmark, where religiosity is so private. I mean, we need these questions raised in secular culture as well. So thank you so much, Tyler. We will be in touch, and I will give the word to Renee, who seems to have both a question or a comment, but is also going to wrap up and bring the crowd here to the next phase. Thank you very much.
Yeah, thank you, Niels. Is my microphone working now?
Very nicely.
Good. I'm happy. Yeah, also from my side, Tyler, thank you for this brilliant lecture. What I missed a little bit is the human flourishing part. I don't know whether I didn't get it or where you didn't share it. I know that you're involved in a big project on human flourishing. Maybe you can say some words on that.
Sure, yeah, I mean, it was brief. It was what I was trying to move towards in the description of outcome-wide studies, where we try to look at as many outcomes as possible, certainly health, but also questions of happiness and life satisfaction, questions of meaning and purpose, maybe indicators of character or volunteering, questions of quality of relationships as well. So in these outcome-wide studies, we're trying to include as many well-being outcomes as possible. And again, ideally in the realms of mental and physical health, happiness and life satisfaction, meaning and purpose, character and virtue, and close social relationships. Of course, one's restricted to the data that's available. But we are doing work in trying to expand and empower the sort of set of outcomes that are used in an epidemiologic cohort study. So we've developed a brief flourishing index with 2 questions in each of those 5 domains. Again, happiness, health, meaning, character, and social relationships, drawn from the existing well-being literature, but it's a pretty short set, just 10 questions, so that it could be easily inserted in epidemiologic cohort studies. And in fact, the nurses' health study just a month ago, both 1 and 2 have agreed to insert these in the 2022, I think, data collection effort. So we'll have these questions, these flourishing questions, in the data that I had described. But another effort currently underway is we are trying to launch with Gallup a global flourishing study. And so this study will be 300,000 individuals in 22 countries, which are geographically, culturally, religiously diverse, with nationally representative sampling within each country, and following this panel, this cohort of 300,000 individuals once a year for 5 or 10 years. So we will have a rich set of well-being and flourishing questions, but the funding's coming from the John Templeton Foundation, actually the other 2 Templeton philanthropies as well, and I think 4 other well-being foundations. Rather expensive to pull off, but because Templeton's providing quite a bit of the funding, we have a number of questions on religion and spirituality embedded in this study as well. So this will allow us to look at these sorts of associations over time with longitudinal data and a rich set of well-being outcomes in countries and contexts and religions which have not been previously examined, at least with longitudinal data. So I'm hoping that in the next 5-10 years that this will really help advance research. This will be an open access data resource. So it will be publicly available. So if you're interested in using it, stay tuned. But we've kind of done the translation work and cognitive testing in these 22 countries. We're going to be piloting next month, and then first round of recruitment and data collection later this fall. So hope we can further address the question of the effects of religious community and other forms of religion and spirituality across these different contexts, not just on health outcomes, but on a whole set of flourishing.
Yeah, thank you, Tyler. So this might be something for one of our future conferences. Huh? This might be a topic for our future conferences. Yeah.
Well, this takes time, but yes, I do hope it plays out in due course in that way.
Good.